Right. So I'll start with my talk on endoscopy in concurrent corneal infections and endophthalmitis. No financial disclosures here. Acknowledge Rajiv, who has taught this skill to me painstakingly over many years. So if we look at literature with respect to infectious keratitis and endophthalmitis, be it infectious keratitis progressing to endo or a concurrent keratitis and endophthalmitis, there is a lot of literature. If we summarize the key take-home points, it tells us that keratitis-associated endophthalmitis forms a relatively small subset in practice per se around the world. But if you look at the Indian or the subcontinental scenario, it is much more in our clinic as compared to the Western world. 30 to 40% of them do not reveal any organism. But what is a standout finding is that evisceration rates can vary from 27% to as high as 60%. So that tells us, though it may not be as common as the other forms of endophthalmitis that we see, once you are faced with this sort of an entity, the chances of losing the eyeball is very high unless you do something quickly. This particular paper actually assessed risk factors for endo requiring evisceration or enucleation, and then they found that a corneal ulcer related endophthalmitis is an independent risk factor for losing the eye. If you look at these particular case scenarios, these are typically these scenarios where you have endo inside and cornea having got affected in a way that it does not allow you direct visualization. So what can you do in such cases? You may go for just an intravitreal injection, which will be simple and quick, but the disadvantage is that you will not get an opportunity to have a vitreous clearance. You're not able to assess the retina upfront, so your management can be optimal. Or the second approach should be to do a keratoplasty and a vitrectomy at the same sitting, giving you the advantage of an extensive vitreous clearance and a retina assessment option on table. But the graft haze is still an issue. The graft would get or may get rejected in the post-operative phase. And also now what you have done is you have removed the host cornea. So there is no opportunity for a natural corneal clearance. And this patient is a post-PK patient for life. And obviously it's a laborious process. The third would be a temporary K-Pro with a vitrectomy. Again, the same advantages, but again, similar disadvantages, that it will not allow opportunity for the natural corneal clearance because the host tissue has been removed already. Vis-a-vis, when you look at endoscopy, it allows you extensive vitreous clearance, allows you to assess the retina on table. Cornea surgeon is per se not required at that moment because it is a pure posterior segment procedure that is being done. And it allows for a natural corneal clearance. When I say that, what I mean is you clear the vitreous cavity. You keep the patient on antibiotics with respect to the corneal involvement. Obviously, this will be a subset where the corneal involvement is not severe. But because you are now having an idea of what was there in the posterior segment and you dealt with it, you can treat the corneal affection on a medical basis and thus give the patient an opportunity to actually develop into a scar rather than losing the whole host cornea. Disadvantage obviously being the learning curve. Now, this was a paper which spoke about early pars plana vitrectomy for treatment of acute infectious endophthalmitis. A very good paper which compares timelines at which an endoff is intervened for. And this paper clearly concludes that in today's scenario, the quicker you clear the vitreous cavity in an infective endophthalmitis, better will be your results. So in that scenario, an endoscopic approach gives you the best chance to immediately know what the scenario inside is and have a complete clearance of the posterior segment. Now let's run through 3 case scenarios. This one was a 9-year-old female, history of trauma with a wire 6 days ago in the left eye, previous corneal intervention done elsewhere 3 days ago, and presented to us with a vision of PLPR accurate. This is what the eye looked like. Repaired tear, you can see an infiltrate around it, an immune stromal infiltrate around the cornea. The ultrasound showing echoes throughout the vitreous cavity. In the primary intervention, a tissue adhesive was put at the site of the corneal tear repair, and a vitreous biopsy was taken as an emergency basis. The vitreous biopsy grew in the lab, and it came out to be an Enterobacter species. So what do we have here? We have post-trauma etiology, which is a negative prognostic factor. Gram-negative organism, again a negative prognostic factor. A relatively young patient, or rather a young patient, 9-year-old. So if you do a graft, high chances of graft rejection. and no posterior segment view up front. So you don't really know what the retina is like. So classical case where an approach with endoscopy will help you. So what we did is we entered. Once we entered inside, we saw these dense exudates. Meticulously, all the exudates were cleared out. And as we cleared the exudates, we could see the retina was attached inside well. And on the posterior pole, though there was a cystoid macular edema, there was no hemorrhage or necrosis. Once we found this, intravitreal antibiotics was given. The patient was followed up medically. And this is what we had 3 months down the line. If you see, the area has completely scarred. The cornea has completely cleared. Had we gone by the conventional approach of doing a K-Pro or a therapeutic keratoplasty, we would have lost the host cornea and we would have had a graft in place, putting the patient to a risk of rejection throughout life. This is what the fundus ended up with a dramatic improvement of vision. She reached 6/18 and 12. A second scenario. 12-year-old male again complains of decreased vision in right eye since 4 days, pain, watering, injury with a needle prick, and a PLPR inaccurate presentation. So this is again how the cornea looked like. Epithelial defect with infiltrate and a tear. Again, a stromal immune ring. Stromal immune rings tend to tell you that it's a fungal infection, or if it's a short history, give you a clinical indicator that it possibly could be a Gram-negative organism. The vitreous cavity showing a lot of exudates, retina apparently looking attached. Again, a vitreous biopsy that was taken revealed it to be an Enterobacter species. This patient again underwent an endoscopic procedure wherein we went in, cleared out the vitreous cavity to the extent possible. We were able to reach the posterior pole. And when we reached the posterior pole, similar to the case that we just saw, we saw that the posterior segment looked viable. So here, the patient underwent a fluid exchange and underwent a silicone oil injection in view of the Gram-negative etiology. This is what we were to begin with, and this is what we ended with. So you can see a little bit of BSK that has come up due to the silicone oil presence because the patient was lost to follow-up and the SOR had got delayed. But very satisfactory, this is what the posterior pole looked like. And this patient reached a vision of counting fingers at 3 meters. The last, an 52-year-old male, reduced vision in the left eye along with whitening progressive since the last 4 weeks. Presenting vision again, PLPR inaccurate, was taking topical antifungals and antibiotic drops elsewhere. Had two visits elsewhere where he was advised evisceration, and he just came to us for another opinion to see whether the eye could be salvaged. This is what the presentation was. A severely melting cornea right in the center, a dense infiltrate, hypopyon, immune ring, and the posterior segment showing a lot of exudates. With this sort of a presentation, PLPR vision, I think for most of us, this seems to be a scenario where possibly the eye is lost. This is what we also had on our mind, but we thought that we would go in, possibly see what the posterior segment looks like, and then see if we had any outside chance of salvaging. So this patient, when he was taken up for surgery, this was something which was really a big learning lesson for us. We went in, we cleared the vitreous cavity like we would conventionally do in an endoscopic approach. And surprisingly, when we reached the posterior pole, the disc, macula, vessels, fovea, everything was pristinely healthy. In fact, it was so pristinely healthy that we had called our cornea colleague on table to replace the cornea with a graft, which was meticulously done. And down the line, this is what the patient looked like 1 week post-op. This is what he was 1 month post-op. And this is what he was 3 months post-op with 2200 vision. So look at how this retina is looking like. And just imagine what the pre-operative picture was and the fact that he had been advised evisceration elsewhere, which in the given clinical scenario and the given look, one would not be tempted to say that that possibly was a right clinic call. But this was something that we learned, that even if things look extremely bad outside, a B scan shows you a lot of echoes, the retina could be well viable. We have collated our experience in a few papers, one where we have put in our experience in endophthalmitis, where in 33 cases, we saw that as the literature mentions, evisceration rate of 14 to 43%, in our study, we noticed that we had evisceration requirement coming down to 3%. only one out of these 33 eyes actually progressed and we had to eviscerate. We've also shown that if you do a prompt endoscopic vitrectomy in post-trauma cases where the cornea is bad, this avoids unnecessary keratoplasties by giving the eye an opportunity to clear out the host cornea. And also in cases where you clear off the endophthalmitis, are left behind with a corneal scar and go ahead and do a secondary keratoplasty, you will have much better visual outcomes than attempting everything in the first go as per the conventional approach. So in conclusion, microbial keratitis with coexistent endophthalmitis is an uncommon but a grave clinical presentation. Aggressive management is warranted to achieve globe salvage. Conventionally, posterior segment access can be achieved by a K-Pro or a keratoplasty to allow for a pars vena vitrectomy. Endoscopy, though, circumvents the necessity of such a labor-intensive approach, allows for a natural resolution of corneal opacity in appropriate cases, and also avoids unnecessary keratoplasties in eyes with a poor posterior segment. So thank you very much for the attention. And in case there are questions from anyone, I'll be happy to take them.